in 5, 4, 3, 2, 1.
Good morning or good afternoon, everybody. We're going to give it a few more seconds while the final few people are logging into the webinar. Welcome, everyone. We're delighted to have you join us for today's webinar from REGENXBIO, who will be sharing the results from their phase 1/2 AFFINITY Duchenne clinical studies with RGX-202 in patients with Duchenne muscular dystrophy, as well as providing information on the design of their pivotal phase 3 study. I'm Michael Kelly. I'm the Chief Scientific Officer at Cure Duchenne, and I'm going to get us started with a bit of housekeeping. We will have the opportunity for Q&A today, and you can click on the Q&A button at the bottom of your screen and submit questions anytime throughout today's presentation. We'll have a moderated Q&A session at the end of the webinar, but may not have time to answer all of the questions live. For those left unanswered, we'll work with the REGENXBIO team to follow up with you after the webinar. After today, this webinar will be available on Cure Duchenne's website as a resource for the community in case you'd like to share it with others. So let me begin. REGENXBIO's approach to gene therapy as a treatment for Duchenne utilizes a unique microdystrophin gene that has been specifically designed to include an extra feature of the important C-terminal region of the dystrophin gene. RGX-202 microdystrophin is larger than other constructs, and because of this, we've been following their clinical trial closely to better understand how this larger microdystrophin gene would function in Duchenne patients. To talk more about this and their recent results, we have Dr. Steve Picola, the Chief Medical Officer at REGENXBIO, and Dr. Naz Dasgir, the Clinical Development Lead, to walk through the latest results from the phase 1/2 AFFINITY Duchenne trial, and they'll take time to introduce their phase 3 AFFINITY Duchenne pivotal trial that has already begun to enroll its first patients. So without further ado, let me hand it over to Steve to get us started this morning.
Thanks so much, Mike. My name is Steve Picola. I'm the Chief Medical Officer at REGENXBIO. And I first wanted to say how excited we are to have the opportunity to collaborate with you, Mike, and Deborah, Leanna, and the whole Cure Duchenne team, not only for this webinar, but in general for our ongoing collaboration. This is so appreciated by us, not just because of your expertise in Duchenne space and your perspective that you bring of the critical aspect of patients and families, but also I don't think we get enough of a chance to say how much inspiration we get from all of your dedication, and that honestly extends all the way from our bench researchers all the way up to Naz and Viv in terms of our clinical development and our excitement about advancing RGX-202. So our mission at REGENXBIO, and a little background on REGENXBIO before we get into the meat of today's webinar that Naz and Mike will be doing the lion's share of, as well as all of you at home with your questions that you'll bring forward. So first, REGENXBIO, our mission is to improve lives through the curative potential of gene therapy. And we've actually been leaders in the gene therapy space for over a decade now. And this has largely been possible because of our own AAV vectors that include AAV8 and AAV9 most notably. And these have become the most clinically validated gene therapy vectors in the world across various indications to deliver safe, efficacious, and importantly, durable gene therapy. And in fact, the first ever in vivo systemic delivered gene therapy, Zolgensma, for the treatment of spinal muscular atrophy, utilizes one of our vectors and has been administered to several thousand children around the world. And today we're going to talk about a different program, RGX-202, our investigational gene therapy for Duchenne, which utilizes our AAV8 vector and has numerous other differentiating features that Mike has already nicely raised, and Naz is going to speak a little bit more about before we get into Q&A. And so again, thank you to Cure Duchenne for this opportunity to present an update on our program. We are super excited to be in pivotal late-stage development. Please know that we are deeply committed as a company to helping improve the lives of boys with Duchenne through our development of new treatments. And so we now are going to transition to the focus of the webinar, the RGX-202 program, and the interim results we've seen to date, and also the details of the ongoing pivotal trial. We're fortunate to have Dr. Naz Dastagir here to walk you through these updates. Naz is not only the RGX-202 clinical development lead at REGENXBIO, she also is a practicing pediatric neuromuscular specialist. So Naz, please take it away.
Thank you so much, Steve. And please let me echo my gratefulness to the Cure Duchenne team for having us here today. It's so important to have you in our lives and to have this venue to speak about our program. So we're grateful to you. So we at REGENXBIO, our ultimate goal is to seek to improve lives through the curative potential of gene therapy. We have pioneered the landscape of adeno-associated virus gene therapies, as Steve mentioned, and thousands of patients have been treated with our approved and investigational medicines built on our NAV technology platform. We are advancing late-stage gene therapies for patients with retinal and rare disease. Our lead candidate is Duchenne muscular dystrophy. And we have an expertise and end-to-end capabilities at REGENXBIO, and we're leading the future of one-time treatments. We have a fully integrated manufacturing and fill-finish capability to support multiple potential product launches. So I'm going to talk to you a little bit about RGX-202, which is our drug. RGX-202 is designed to sorry, my screen keeps malfunctioning on me. RGX-202 is designed for improved function in Duchenne. It is the only microdystrophin gene therapy with the functional elements of the C-terminal domain, also known as the CT domain, which is found in naturally occurring dystrophin. So I'll kind of just review this with you just for educational purposes. This is an overview of all the different companies that are either commercially approved or in research right now. So AAVs are also known as adeno-associated viruses. There are different types of AAVs that are often selected for specific delivery to specific tissues. So everyone that you see here, AAV8, RH74, SLB101, is targeted so that you can get into the muscle tissue. We chose AAV8 because we believe that it gets to the skeletal muscle well. And that is because we're using this viral capsid, or the house of the virus, the adeno-associated virus that doesn't cause disease in children, but you actually empty out the viral DNA and you insert a manufactured gene. That manufactured gene is somewhat chauffeured into the muscle cells, the entire body, with a one-time infusion with the help of something called a promoter. So you can see the different companies use different promoters. We have chosen SPC 512. And there's only so much space in this viral house or capsid. And so you have to pick and choose the different elements of dystrophin that you can include in this house, because dystrophin is a very large protein that can't be squished into one of these big viral vectors. So you have to pick and choose. And what each company actually picks and chooses is different parts that they think might lead to a better functional transgene, which then codes for the microdystrophin that we are using to support the muscle membrane. our transgene is unique in that we include this green little oval here to the far right called the CT domain. And we hope that this CT domain will uniquely differentiate us as we've seen with preclinical studies in mice. I'm going to go over here. So here is the review of the role of the CT domain or C-terminal domain and how it could preserve muscle health. So preclinical studies are, again, in mice, in the MDX mice, also with mice with Duchenne muscular dystrophy. They indicated that the CT domain in the RGX-202 microdystrophin enables muscle resilience. So if you look at the figure over here, hopefully my cursor is showing up, you can see the initial force that a mouse can generate if they're a control mouse, which means they don't have disease. And then you have a mouse with Duchenne, and you could see that percent of force decreases from about, 68% to about 20%. So if you administer to the mouse microdystrophin, the transgene for RGX-202, without the C-terminal domain, you generate better force, but you can optimize that with the addition of the C-terminal domain. And it's this preclinical data that allowed us to make the decision to include it in the transgene, which we now administer to our participants in the study. So how can the CT domain contribute to improved outcomes with RGX-202? So the functional microdystrophin CT domain significantly enhances the restoration of the dystrophin-associated protein complex in mice. The dystrophin-associated protein complex is a series of proteins that, like dystrophin, support or are like scaffolding for the muscle membrane or the sarcolemma. They can it can prolong microdystrophin activity. So the CT domain increases the half-life of RGX-202, which remains in the muscle fibers longer to strengthen muscle. So what is half-life? It's how long it takes for half of the drug to be metabolized or disintegrated. And in terms of muscle health, the CT domain in the RGX-202 microdystrophin protected against contraction-induced damage, enabling a better muscle recovery. So, as we all know, in treating patients with Duchenne muscular dystrophy, eccentric contractions in particular seek to break muscle and then rebuild it. But with Duchenne, you have difficulty with rebuilding without fibrosis or fatty replacement. But the CT domain here in our RGX-202 microdystrophin protected against this contraction-induced damage from everyday activity and can help enable better muscle recovery. So I'm going to go over the AFFINITY Duchenne study. We are going to give you an overview and review some data from our phase 1/2 study. So phase 1/2 studies typically focus on safety, primarily safety, and then secondarily efficacy. So our AFFINITY Duchenne phase 1/2 portion had a few key eligibility criteria. We initially started in 4 to 11-year-olds, but expanded to include 1 to 11-year-olds, bringing the study to younger patients with the hopes of being able to address an unmet need in kids who might be diagnosed with newborn screening, which is getting implemented in different states. You must have genetically confirmed Duchenne muscular dystrophy. At this time, the mutations that we include are in exons 18 and above, but we are looking to amend our protocol to make it a bit more inclusive, so stay tuned. If you're over the age of 4 to 12, or 4 through 11, you must be able to complete a 100-meter walk without the use of assistive devices. For the 1 to less than 4-year-olds, you just need to be able to complete a 10-meter walk without the use of assistive devices. And you must have no pre-existing antibodies to the gene therapy or the viral vector capsid, which in our case is AAV8. So typically AAVs don't cause any symptoms. You may not know you've been exposed to it in the past, so the only way to really figure that out is with a blood test. What we've done so far in our study is we've started off by evaluating dose level 1, which is 1 × 10^14 genome copies per kilogram. We tested that in 3 patients and then proceeded to dose level 2. Dose level 2 was twice the amount of vector. And that was 2 times 10 to the 14th. And when we got the okay that that was safe in those 2 patients, we got an okay from an external data monitoring committee. External safety monitoring committee that said, okay, go ahead, expand this study onto dose level 2 and dosing 5 additional patients. So we did that. So everywhere that you see a green check is what we've fully enrolled up until this point in our phase 1/2 study of AFFINITY Duchenne. Once we got to dose level 2 in our 4 to 11-year-old patients, we thought, you know what? Again, addressing this unmet need in the newly diagnosed on newborn screening that'll be coming up more and more, why not go ahead and open up the study to 1 to 3-year-olds? So we did that, and we started off with 2 times 10 to the 14th genome copies per kilogram. And we've dosed a couple patients in this age group, but we still have room to fill up to 5 patients in this phase 1/2 portion of our study. So you might be thinking, what does this study involve? So down here, you'll see the administration and assessment timelines. So at baseline, which is the screening period, which could be up to 60 days in duration, just to give flexibility with scheduling and whatnot, you will have some baseline assessments. So one of the main things is obviously screening for your antibodies to see if you're positive or negative. Then you also need to get your safety labs checked out. You need to have a baseline functional outcome assessment just to see what your baseline function is, motor function is. We also get baseline muscle imaging and cardiac imaging or heart imaging. And we also get a baseline muscle biopsy. That's to check to see how much dystrophin expression a child might have at baseline, because even if you have Duchenne, you might have a little bit of dystrophin in the background. That dystrophin may not be functional, but it's good to know if it's there. We can also look at the degree of fibrofatty replacement that's in the muscle tissue at baseline, get a better idea of what kind of baseline muscle we're dealing with. And then during this pre-dosing stage, after we get all this baseline testing, we initiate an immune suppression regimen. Our immune suppression regimen has 3 different drugs that we administer to really protect our kids in the study from a potential immune response to the vector that's administered. Because what you get with gene therapy as a viral load is a really high amount of virus that will mount a huge immune response. So what we do is we try to nip it in the bud before it gets too out of control and potentially trigger some safety events. We nip it in the bud ahead of time, dose the drug, continue with immune suppression at full dose for about two months, and then taper to off in the 3rd month. After that immune suppression is off, at 3 months after dosing, we then proceed with getting a second muscle biopsy. This is our follow-up muscle biopsy where we seek to quantify how much microdystrophin we can express in the muscle tissue that we extract from the muscle biopsy. So what that lets us know is not only that the virus is delivering the drug to the correct place in the skeletal muscle, but that the transgene is also creating the protein that we need to see. And we can also see that the protein is localizing to the muscle membrane on a study called immunofluorescence, and we'll have some pictures about that. We only do 2 muscle biopsies throughout the duration of the study, and after that, we proceed to get continuous muscle function and strength assessments, muscle imaging, and obviously during the phase 1/2 study, as I mentioned earlier, really focus in on the safety and tolerability of the drug. So there's a lot of demographic information here on the patients, so I won't bore you with too many details because it's a huge graph to go through, but key features here are that we've dosed 4 to 11-year-olds with dose level 1. At dose level 2, we've dosed children between the ages of 1 and 11. Our maximum age that we have dosed is 12.1. Our youngest is 3.7. The maximum weight we have dosed, which really matters in terms of safety, in terms of how much virus we've delivered and had a good safety profile to date, is 35.5 kilograms. And our maximum follow-up time from dosing at dose level 2 is 11.8 months. At dose level 1, it's 19.4 months. You may be familiar with the functional outcome measures from other webinars or just reading up on your own time. We have the North Star Ambulatory Assessment, time to stand, 10-meter walk run, and time to climb. What you can see here are the baseline average scores on the patients who have been in our study. going to go over the safety data here. So here you go. Interim safety data. So our RGX-202 treatment emergent adverse events are listed below. We have no, I always knock on wood, everybody laughs when I do that, but I always never take it for granted. We have no serious adverse events. We have no adverse events of special interest. These are adverse events that we think are relevant to our particular product that would be piquing our interest. This includes central or peripheral neurotoxicity, which is sometimes a concern with gene therapy, drug-induced liver injury, thrombocytopenia or low platelets, which can lead to dysfunctional clotting, myocarditis or heart inflammation, or myositis or muscle inflammation. So in all age ranges, all doses, all patients, we have not had any of those. We, of course, do have some adverse events or drug-related AEs, which we see with other gene therapies as well, which include some nausea, some vomiting, and fatigue, which all resolve. So that really makes us feel good about our drug, that it's been well tolerated in all patients at both dose levels with no serious adverse events or adverse events of special interest. So if you recall, I was talking about that follow-up biopsy that we do. So that biopsy, that data that we get from the biopsy is a biomarker. So this biomarker that we obtain from muscle supports consistent, robust expression, transduction, and sarcolemmal localization of RGX-202 microdystrophin. Okay, so expression means that the microdystrophin is in the tissue. We know that it's in the muscle cells, and we know that it's being expressed in the correct location. It's rimming the muscle membrane. So the percentages of microdystrophin that we can quantify on a study known as Western blot are listed in this chart. At dose level 1, in the 4 to 7-year-old age group, we have an average microdystrophin percentage of 60.6%. In the 8 to 11-year-old age group, it's 10.4%. When we move to dose level 2, in the 4 to 7-year-old age group, it's 77.2%. In the 8 to 11-year-old age group, it's 39.7% on average. Vector copies per nucleus has to do with how much vector is actually getting into the muscle tissue. And you can see there's a little bit of a dose response with the higher dose that we're giving. So at dose level 1, we have in the 4 to 7-year-olds 9.8 copies per nucleus, in the 8 to 11-year-olds 5.4 copies per nucleus. But when we go to dose level 2, we have 55.4 copies per nucleus and 17.8 copies per nucleus in the 8 to 11-year-olds. And we hope that that amount of vector that's lying around in the tissue is just going to keep spitting out that extra protein that you need to support your sarcolemma or your muscle membrane. And then positive fibers has to do with how the muscle membrane lights up. So if you look at this picture on the right here, you're looking at the fiber intensity. So at baseline, when there's no dystrophin expression, everything is blue. When your microdystrophin comes into play, you add some additional color. So yellow is low intensity, orange is medium intensity, and red is strong intensity. And this is how much your protein is actually localizing to the muscle membrane in the pictures that we're taking of the muscle biopsy. So it reassures us again that the protein is getting to the tissue and it's expressing itself in the correct way. So we're going to talk a little bit about how we're going to present the data to you in this presentation. We're going to present the actual data that we have from the patients, but we're also going to compare it to natural history because we have no placebo in this phase 1/2 study. And we want to show how our patients are doing compared to their projected natural history of Duchenne progression. So functional data was obtained at clinically meaningful time points. For all of our dose level 1 patients, we've had 12 months of data after administration, which we will share with you today. For our dose level 2 patients, we only have 9 months of data after RGX-202 administration, which we will share with you as well. We think 9 months is the earliest time that we can really show you clear functional data because it's a good 6 months after you've weaned off of the immune suppression regimen. The method for matching to an external control, so we had to be very intentional in how we chose to do this because we know that there is a lot of heterogeneity between patients in their baseline disease stage, their rate of disease progression, and their anticipated efficacy response. So we use a few criteria to match. So what we do is we take the patients that we have and we then compare them to natural history data sets that we have, that we've acquired. And those data sets include about 402 patients. And we had to make sure that they were exposed to steroids, they had at least 12 months of data, and they matched with certain criteria at baseline with their age, time to stand, time to run, walk, and time to climb. And here you go. So here's our data. So our dose level 1 participants demonstrated improvement in function and exceeded external controls at 12 months. So what you're seeing here with this delta symbol or this triangle is how much they improved as compared to their external control, meaning what you would expect to see with their natural trajectory if there was no intervention in place. What you see where it goes, like for example, with this patient here, you'll see it goes to negative 1.2 or so. That is how much they improved compared to their own baseline. But again, as we know with Duchenne muscular dystrophy, you don't even stability is a good thing over the course of a year. Here we're comparing what they would actually, based on their baseline prediction, be expected to function at for their time to stand, for example, and how much better they're performing. So what you're seeing again with the delta is that difference from the external control. So here negative means it's faster. So they improved by 2.9 seconds compared to natural history on the time to stand, improved by 1.1 second on the 10-meter walk-run test, and improved by 1.8 seconds on the time to climb. And that's the time to climb 4 stairs. And their North Star ambulatory assessment compared to external control is 4-point increase. But you can see compared to their own baseline, again, stability would be great, but we still saw improvement around 2.3, 2.4 for the patients who just received dose level 1. Now, dose level 1, we chose as the lowest effective dose, but obviously we went on to dose level 2, as I mentioned before, and dose level 2 is delivering more drug. With preclinical studies in the mice, we anticipated it was going to do better, and that will be our selected dose. So just a reminder that dose level 1 is not our selected dose, and we're still seeing benefit from that. The other thing we did that we could do with our dose level 1 patients, because we had 12 months of data, is compare them to what's been defined by the FDA and is based on a paper by Tina Duong in 2021, which is the minimally clinically important difference. So this is what allowed for the approval of Elevidys, for example, and also vamorolone. And we surpassed that minimally clinically important difference with our dose level 1 patient. So RGX-202 treated patients are in blue, and the minimally clinically important difference is listed in gray. Then our pivotal dose, which is 2 × 10^14 genome copies per kilogram, also demonstrated improvement. But this is at 9 months because we're still waiting on the 12-month data, but we wanted to share this with you today. So we anticipate that hopefully this divergence from what you would expect from natural history will get better over time, but obviously we'll be able to present that to you at a later date. So we had 2 patients, and these patients are older than what you've typically seen presented from other studies. Our first patient here is an 8-year-old, and our second patient is a 12-year-old. And we compare them to the natural history control, which is in the gray boxes, and in blue we have how our patients are performing. In the 8-year-old compared to natural history, he improved by 0.9 seconds. In the 10-meter walk run, he improved by 0.7 seconds, and in the time to climb, he improved by 1.2 seconds. In the 12-year-old, he improved by 3.1 seconds. The 10-meter walk improved by 1.3 seconds, and the time to climb improved by 2.7 seconds. So we're seeing really great signs here. We're really excited about the results. And of course, we're going to wait and see how sustainable this is with our 12-month data, if not improved. And also we have the North Star ambulatory assessments on the far right. You'll see that the 8-year-old improved by 2.8 points compared to natural history. Our 12-year-old from baseline improved by 10 points, but we don't have a natural history control for him in the data set that we currently have. We are still getting additional data to compare to, but you would anticipate that a 12-year-old would theoretically have, at least what the 8-year-old is demonstrating. So it'll be above 10 for the change. That child is not going to get better. That child would only be historically anticipated to get worse, but we're showing a 10-point improvement in the North Star Ambulatory Assessment. So we're going to show you again the timed function test here as an average for all of those dose level 2 patients. So as an average between the 2 patients, they improved by 2 seconds compared to natural history. And the 10-meter walk on the time to stand, in the 10-meter walk run, they improved by 1 second compared to natural history. In the time to climb, they improved by 2 seconds compared to natural history. And the average improvement in the NSAA was 7.3 seconds. But again, we don't have the natural history comparator for the 12-year-old. So take that with a grain of salt. It would most likely be higher than that. And then what we do as part of our study is we really value input from family members because it's not just what we're seeing on the exam, but what the family and the patients are experiencing at home. And we saw that caregivers reported improvements in the home and community environments as measured by the POTSI. We had improvements in skills like running, riding a bike or a tricycle, climbing stairs, walking in the community, and participating in recreational activities and sports with peers. So in the interim summary here for our phase 1/2 study, we see that we have positive safety, biomarker, and functional data that demonstrate the potential of RGX-202. It's been well tolerated in 11 patients across both dose levels with no serious adverse events or adverse events of special interest. Our biomarkers or muscle biopsy, for example, support consistent, robust expression, transduction, and muscle membrane or sarcolemmal localization of RGX-202 microdystrophin. And the participants treated with RGX-202 demonstrated clinically meaningful improvement in the functional outcomes at both dose levels and exceeded comparisons using natural history external controls and the minimally clinically important difference. So what I'm going to do now is just move on to our pivotal study, which is our phase 3 portion where we're trying to prove efficacy of our drug. We have a pivotal trial for accelerated approval that is currently open and enrolling. We've already dosed our first patient, and we got alignment with the FDA on the design and the accelerated approval pathway. So what we're going to do is we're going to use for the accelerated approval portion of our phase 3 study, we're going to use RGX-202 microdystrophin as a surrogate endpoint likely to predict clinical benefit. We're going to be, we are expecting a biologic license application in 2026 using accelerated approval to include approximately 30 patients at dose level 2. And the eligibility criteria for our pivotal study will be a little different. We're not going to have an upper age limit. So we're going to be enrolling kids that are 1 and above. They must have genetically confirmed Duchenne muscular dystrophy. Currently, like I said, with mutations in exons 18 and above, but that is going to change hopefully early next year. So stay tuned. And they need to have no pre-existing antibodies to the gene therapy or the AAV8 capsid. So just to talk about the endpoints or what we're going to use to prove that our drug is working, the primary endpoint is the proportion of patients with greater than 10% microdystrophin levels. Our secondary endpoints include the time function tests like time to stand, time to walk, run 10 meters, and time to climb. And we're also implementing the SV95C for the 1 to 3-year-old patients as a secondary endpoint. The SV95C stands for stride velocity 95th centile. That's kind of like a wearable where we can get hours of data outside of a clinic environment, which may not be the best to assess kids and assess how that changes over time. And our exploratory endpoints will be the NSAA and the SV95C for the 4 and over patients. We have multiple sites across the US open right now. That includes Stanford, UT Southwestern, Arkansas Children's Hospital of Richmond, and Lurie Children's Hospital in Chicago. These are amazing teams. We're very glad to have them as part of our network. And before I conclude, I just want to put a plug in for our Affinity Beyond study, which is an anti-AAV8 antibody assessment study. So Affinity Beyond is a study just to check for your antibodies. So that's not part of Affinity Duchenne. per se, but it will let you know if you could potentially be eligible for Affinity Duchenne. There is a central site at Rare Disease Research with Dr. Han Fan. And basically, you do a virtual call with her. She kind of goes over your history. There's no intervention other than a blood draw that happens. And that blood draw takes place with the help of a network of nurses who are across the country who will come to your home and draw the blood, send the test out for assessments. And if you are negative for your antibodies and potentially eligible for Affinity Duchenne, Dr. Han will have a conversation with you about that. And then you would be it would be your decision on whether or not you'd want to contact the individual sites to be enrolled in the Affinity Duchenne study. So we've tried our best to make this as easily accessible as possible to all of you and kind of reduce the burden of getting tested. At present, this is only available in the United States. We don't have a system yet set up outside the United States. And in conclusion, I just wanted to give some acknowledgments. Of course, first and foremost, our participants and their families. We understand this is a lot of work to be a part of this, but it's history in the making, and we're so grateful for you. Thank you. And again, to the investigators, and very importantly, the study coordinators, and also our team at REGENXBIO. So thank you so much. This is how you can reach us at Duchenne@regenxbio.com, and we have clinicaltrials.gov listings here for either Affinity Duchenne or Affinity Beyond. I think we can move to Q&A.
Yes, thank you for that. That was
Sure.
a tour de force and a great presentation on a program that's clearly evolving very nicely. Well done. As you say, we've now got time for a moderated Q&A session with the questions that have been submitted. I've seen a number have already. If you have any more, click on the link and add your question, and we'll try and get to it over the next short while that we have left. Now, let me begin by just asking a question here around the differentiation. This program began around the ability to build a larger gene. And I seen the earlier preclinical slide where there was a clear benefit of that had the extra CT region compared to one that did not. How much is that playing out in the clinic? Do you know how much it's contributing into the benefit that we're actually seeing in here?
You mean in terms of how much of the gene we can include in the transgene
No, I
itself?
mean, how much of a role is the larger gene playing in the improvements that you're seeing?
Oh, I see. Yeah, so I mean, at this time, obviously we're seeing what we see from our functional data, and we can kind of hang our hats on what we see preclinically, like what we saw in this slide here, like what we got in the mice without the CT domain versus what we got with the CT domain. I mean, to be fair, the only way we would know how much of a benefit it's playing into would be to test some kids without CT domain versus with CT domain. But that being said, if we go based on the assumption of the preclinical data showing that the CT domain benefits and we show superior functional data compared to other companies that don't have the CT domain, I would think that the CT domain is playing a big part.
Yeah, I agree. I think that also, like I look at the drug product as a combination of different things. You know, you've got a different capsid, a unique promoter along with the transgene. But playing into that also is the focused immunosuppression that you've built into that. And I think that combined with the drug product is likely to play a role in the data that you've got today.
Yeah, there's some presumption, at least I can say on my part, that this has been described in other presentations too at different meetings, that as you're giving your gene therapy, you actually start within hours forming antibodies to the gene therapy itself. So besides getting the benefit of a reduced adverse event profile with the addition of the immune suppression that we're giving, could you, in theory, be reducing the amount of antibodies to the drug itself as you're doing the infusion and allowing for better vector expression because you're suppressing the immune response that would otherwise destroy it?
Mm-hmm. Can I ask about your thinking with respect to ex-US sites?
Yep, so we're very interested in going into ex-US. I think first on our list is Canada, and then hopefully Europe in the near future.
Excellent. And I also noticed that there's no age limit for, at least upper age limit for the pivotal trial. You know, I'm delighted with that. This is just going to be purely included on functional assessments on the boys.
Yes. So basically, the reality is, and one thing that I didn't include on here is that our for our pivotal study, the time to stand requirement
Mhm.
for the 4 and over patients is less than 7 seconds. So as we all know that um, Duchenne, Becker, it's really a spectrum, and sometimes in the middle, it's really hard to draw the line between what's severe Becker or a mild Duchenne. But basically, if you do have older patients, like say a 15 or 16-year-old who is weak but still able to do a time to stand in less than 7 seconds, you're probably selecting for a milder Duchenne patient. We rely upon the diagnosis to be given by the primary investigator. So they will define the patient as Duchenne. We don't exclude specific mutations that may have a milder phenotype in our study because we're really comparing them to their baseline, and also an external control. And so, for example, I know some studies will exclude exon 45 deletions. We don't do that. Some studies will exclude in-frame mutations. If you're symptomatic and your PI calls you Duchenne, we know that there's some in-frame mutations that present as historically out of frame, like particularly in the actin binding domain. They might have a more severe phenotype. So we don't exclude based on that.
Thank you for that.
If I could jump in with just to
Certainly.
clarify, yeah, just looking at some of the questions coming in. So you kind of said it though. There's no upper age limit for this
Right.
pivotal trial, but the individuals still have to be ambulatory
Correct.
at
Now,
this time.
there are goals in the future because we're constantly developing to open this to a wider base of patients. But at present, we're just enrolling ambulatory patients who are able to do the 100 meters on their own and complete a time to stand of less than 7 seconds. And actually, with the pivotal study, full disclosure, we also put in a lower limit for the North Star, which is 16.
Okay. Thank you for
Mhm.
that. And then
Sure.
just to go back to the immunosuppression question, I think there's a little clarification for some individuals might be helpful because there's a question of why do you have to be tested for the virus if you're going to be immunosuppressed?
Oh,
And
great question.
so, yeah, go
Yeah,
ahead.
sure. So it's a really great question. So basically, when you look at the antibody results in patients, you're looking at a little bit of a titer of sorts, and the numbers can vary wildly. You can get something that's like 1 to 30, and then you could get a patient that's 1 to 150,000, for example. So the amount of antibody that you have varies wildly. So, but we don't actually have a titer cutoff. So, for example, Elevidys uses, I think, 1 to 400. We don't have a titer cutoff, although our assay cuts off at 1 to 20. So they can't detect below 1 to 20. So anybody less than 1 to 20 enters into our study. We are definitely interested in establishing a potentially a higher titer cutoff, but that's probably for the lower end of the patients. For those with really high titers, with really high antibodies, the immune suppression regimen by itself isn't going to cut it to get rid of that immune response that could potentially be mounted. So having the presence of the antibodies there is a twofold problem. One, if you have really high antibodies to begin with and you get the infusion, you might render the drug ineffective. And then two, you might mount a very large immune response to the drug that's being delivered because, again, we're giving unnatural amounts of virus, like beyond all gene therapy does, beyond what you would get just from catching it in the wild. And basically, you would actually mount a really big immune response to the drug itself and potentially risk serious adverse events as a result of that. So, in short, the immune suppression regimen that we give is not enough to reduce, especially those higher titers. We have not yet tested it in the lower titers, but it's definitely something we're considering because we understand it's an unmet need in the population.
Thanks.
Naz, could I just touch on while we're on mutations and exclusions? Currently, there are a subset of patients that are excluded because of a potential immune risk. Are you thinking about at some point in the future of trying to get around that, mechanisms to deal with it, the timing of that? What's the company's thoughts and your own thoughts about trying to attack and make the drug more available to a broader population?
Yeah, so we're actively trying to do that. So stay tuned early next year to expand it to a wider population of patients. Um, and hopefully that's going to open the doors to a lot more families. And we're excited to be able to provide that. We do think that our unique experience with our immune suppression regimen puts us in a place where we can potentially try to test the limits of how much safety we can provide with it. So we're going to be starting with probably not the highest risk mutations, which at this time are 8 and 9 deletions, but less high risk. And then if we feel like we've got a good safety profile with those less high risk patients, we definitely would love to do our best to address the unmet need in the 8 to 9 deletion community.
Leanna, any other questions?
Yeah, I just thank you so much, Naz. Thank you for sharing the information also about the Affinity Beyond, which is where you can find out about your antibody titer. So I noticed that the criteria for that is a little bit tighter than for the phase 3, right? The age is 0 to 11. And I was wondering if there's
Great catch.
plans to expand
No,
that
great
out.
catch. Nope, we just have to do an amendment.
Okay. And then the other bit was in that there wasn't, so in the Affinity Beyond, are you looking at a wider array of mutations as well? Or is that at the moment
Yes.
for individuals
Yes,
with,
that's open to any patient of any mutation because I think we anticipated, hopefully in the future, being able to expand our drug to deliver it to other patients with other mutations beyond the
Sure.
criteria as it stands now.
Thanks. I think that was all from me. And
I think the same for me. I'm going to wrap it up. I just want to say thank you for joining our webinar today, and a big thank you to the whole team at REGENXBIO for the work they've done developing 202 and for sharing this really important update with the community. We look forward to further updates as the pivotal trial is now currently enrolling patients, and a BLA is expected in 2026. The post-webinar email will be sent tomorrow, should you have any additional questions. And we'll get in touch with all attendees to let you know when the webinar will be posted online for review or sharing with others if you think it may be appropriate. And thank you again for joining us and have a great rest of your day.
Oh, it's a pleasure. And thanks to everybody for listening. And like I said, you could reach out to us at Duchenne@regenxbio.com.
Thank you, Naz.
All right. Take care. Bye.